If you want to understand medical prescribing patterns in irritable bowel syndrome, you need to follow the money. I'm Dr. Robynne Chutkan, gastroenterologist, microbiome expert, and author, and I am here to help you find gut bliss. On today's show, abdominal pain or discomfort that's usually associated with constipation, diarrhea, or both. A diagnosis that affects between 10 and 20% of the population in the U.S. I'm talking about IBS, Irritable Bowel Syndrome. In the 1970s, we started using the term spastic colon and emphasizing psychological factors in the diagnosis of IBS. We also started to refer to IBS as a functional GI disorder, sometimes abbreviated to FGID. Functional GI disorders is still a term that's used pretty frequently to describe IBS and a bunch of other GI conditions where your GI tract looks normal, but you don't feel normal at all. And the term functional implies that you have symptoms in the absence of any structural changes in the gut. We've also sometimes described IBS as a diagnosis of exclusion, meaning that we've looked for other things like colitis or diverticulosis or reflux, and we don't see anything. Therefore, it must be IBS. In around 1973, there was a series of experiments that involved inflating a balloon in the rectum of people with IBS. And the results showed that someone with IBS had more pain compared to somebody without IBS when the balloon was inflated. And this landmark study formed the basis for the visceral hypersensitivity theory. And the study really represented a pivotal moment in IBS because it demonstrated that people with IBS had a greater sensitivity to internal stimuli, like rectal distension. Basically, distension of your internal organs, your viscera, your hollow organs. And this is a sensation that would not typically be painful in someone without IBS. So it created, as you can imagine, an explosion of interest in the underlying mechanisms around visceral hypersensitivity. And when we come back, what is going on in your body, not just in your GI tract, but also in your brain to explain visceral hypersensitivity in people with IBS when we come back. The Gut Bliss podcast is brought to you by VisBiome, my first and quite frankly, my only choice for a probiotic. Whether you're dealing with irritable bowel syndrome or just looking to restore your gut health, VisBiome can help. It's a medical food for the dietary management of IBS and gut inflammation. Backed by science and clinically vetted by thousands of my own patients. Find your gut bliss with VisBiome. Go to visbiome.com/gutbliss and use discount code GUTBLISS at checkout. There are three mechanisms that are responsible for visceral hypersensitivity. The first is altered gut motility. Your GI tract just isn't moving properly, and parts of the gut are becoming distended, and that creates discomfort. Number two, there are pain-sensitizing substances in the gut that are being released that increase sensitivity in the nerves in the gut. And three, there are changes in parts of the brain involved in pain perception and processing, parts of the brain like the anterior cingulate cortex that can cause a greater response when your organs are distended. And not just a greater response in an experimental setting, like when we're blowing a balloon up in your rectum, but a greater response in a regular everyday setting, like when your GI tract has gas in it, or liquid, or food, which is why one of the hallmarks of IBS is that people tend to be more uncomfortable after they eat a meal, and they often have relief after a bowel movement when their GI tract has emptied. And that's true to some extent for almost everyone. Most of us tend to be more uncomfortable after we eat a meal, particularly if we eat a large meal or we eat a high-fat meal or we eat a meal of processed food. And for lots of people, having a bowel movement is the ultimate detox. I know after I have a big mama jamma poo, I feel amazing. And you probably do too. But the hypothesis, again, is that with IBS and visceral hypersensitivity, the discomfort after eating and the relief after a bowel movement is much more pronounced and exaggerated than it should be. The recognition of visceral hypersensitivity prompted researchers to go out and explore new treatment strategies that targeted mechanisms involved in pain modulation. And that's why we started to see in the 1980s a lot of new treatment strategies that involved pain medication that is not typically what you would think of for a GI condition. But the medical community still was not asking the important question. And that question is why? Why did people with IBS have visceral hypersensitivity? We knew about these theoretical mechanisms, but what was causing it? The studies showed that people with IBS were not any more sensitive to other types of pain. So if you stuck them with a pin, somebody with IBS would have the same degree of pain as somebody without IBS. So it was specifically around this idea of distension of the hollow organs, the viscera. And even though we weren't seeing active inflammation inside those organs, like we would in somebody with ulcerative colitis or Crohn's disease, it was pretty clear that there was something else going on beyond just people being more sensitive to distension of their organs. When we come back, the meeting in Rome that changed everything. You have questions? I have answers. Join me live twice a month for the Gut Club. Go to gutless.com to learn more and sign up for your free trial. It's now 1988, and an international group of gastroenterologists from the US, the UK, Canada, Germany, Sweden, and several other countries meet in Rome to draft a proposal and to try and reach a consensus about the specific diagnostic criteria for IBS. The guidelines they come up with, known as the Rome criteria for IBS, because a meeting was in Rome, those guidelines were published the following year, and they attracted a huge amount of interest, not just among researchers, but amongst pharmaceutical companies. Now, why was consensus about the diagnosis of IBS so important? Well, for one, it was really difficult to do clinical trials on IBS without a clear definition of what IBS was. When we're doing a clinical trial in medicine, we always have admission criteria, meaning the patient has to have certain symptoms or features to be included in the trial. And that's to make sure that we are including patients who actually have the disease. But because the diagnosis of IBS was still somewhat vague, we were talking about functional GI disorders, we were talking about diagnoses of exclusion, it was difficult to perform clinical trials because we didn't have clear criteria. So the Rome consensus and the Rome criteria were actually a big step in the right direction. Secondly, there was huge interest from the pharmaceutical industry. And here we're going to spend a moment talking about how that works. In order to get approval by the Food and Drug Administration, the FDA, a drug has to show efficacy for a particular diagnosis. It has to show that it works. Now, it doesn't have to work well. A lot of times the efficacy is just a little bit better than placebo, meaning a sugar pill, but you at least have to show that it's doing something for that particular disease. And that means drug approval, at least initially, is linked to a diagnosis, and there needs to be clear criteria for that diagnosis. Now, when a physician writes a prescription for a drug, there is usually a diagnosis linked to that medication. But the reality is that once a medication is approved for use by the FDA, we can prescribe it off-label, meaning physicians can prescribe it for any condition once the drug itself is approved for use by the FDA. And off-label prescribing of drugs is common. About 1/3 of all prescriptions for drugs in the US are prescribed off-label, meaning they're being used in people who don't have the diagnosis that the drug was initially approved for. And sometimes that off-label use is life-changing. It may turn out that a drug works for a disease and can bring tremendous relief to someone with that disease, but use of the drug for that disease was never studied in a clinical trial, and so it doesn't have FDA approval for that specific disease. And here's the thing. Getting a drug approved is a really time-consuming and super expensive process. According to a study published in the Journal of the American Medical Association, the total cost of developing a new drug can be as much as $2 to $3 billion. But let's talk about the other side of off-label prescribing, which is the economics. Pharmaceutical companies spend a tremendous amount of money advertising directly to physicians because physicians have the power to prescribe their drug, not just for people who have the disease a drug is approved for, but for people who don't fit the criteria for the disease a drug is approved to treat. Of course, the broader the criteria for the diagnosis, the more people are likely to fall under that umbrella diagnosis. And here we get to the crux of the matter with IBS. When we come back, follow the money. The pharmaceutical industry spends a significant proportion of its marketing budget on reaching healthcare professionals, with estimates suggesting around $20 billion a year. And those are fairly conservative estimates. And this includes tactics like face-to-face visits, providing drug samples, and direct payment to physicians. Yes, that is legal. According to the American Academy of Family Physicians, in 2016, $5.6 billion was spent on prescriber detailing, which means visiting physicians in their office and giving them information about how fantastic the drug is. $13.5 billion for drug samples, again, leaving samples of the drug in the office. Often when the physician gives you a sample, you are more likely to continue taking that medication. And $979 million for direct physician payments. And again, this was according to an article published in the American Academy of Family Physicians. Nobody would be spending this much money if they weren't seeing a massive return on their investment. Encouraging physicians to make a diagnosis of IBS and to prescribe a medication for IBS is big business. The global IBS treatment market is a multi-billion-dollar industry with a projected growth of over $7 billion by 2033. In 2023, the market was valued at almost $2 billion, and it's expected to reach $4.74 billion by 2034. Key drivers of that market include a dramatic increase in the number of people being diagnosed with IBS, increased awareness of IBS, and the development of new treatments. All of this driven by the pharmaceutical industry. So let's circle back to the Rome criteria. They get updated every few years. We're currently in Rome 4, I believe, and they're pretty broad. So broad, in fact, that most people with GI symptoms meet the diagnostic criteria. I'm going to tell you what they are, and you can decide whether, if you went into a doctor's office and mentioned that you had these symptoms, you indeed would be diagnosed with IBS. Number 1, abdominal pain or discomfort that occurs on average at least 1 day per week in the last 3 months. Number 2, the abdominal pain is associated with a change in your stool frequency, meaning how often you're having a bowel movement, your stool form, meaning the consistency of the bowel movement, or both. And number 3, the symptoms have been present for at least 6 months. That is great for the pharmaceutical industry when all of a sudden 20 to 30% of the population has IBS. But it's not so great for somebody who actually has IBS, because a problem with diagnosing almost everyone who has GI symptoms with IBS and then prescribing a medication that may or may not work is that you don't do the heavy lifting of figuring out what is actually making that person's bowels irritable, what is causing their GI symptoms, which is what we're going to talk about in next week's episode. Slicing up the IBS pie to get to the root cause and find lasting relief. I want to leave you with 3 takeaways about where we currently are with a diagnosis of IBS and this issue of pharmaceutical expediency. Number 1, In my almost 3 decades of practicing gastroenterology, I have found that the vast majority of people who come to see me with a diagnosis of IBS actually have a treatable underlying condition beyond visceral hypersensitivity. In fact, visceral hypersensitivity often does not play a role. Number 2, what are those underlying conditions? Many, but here are a few. Food intolerances to gluten or lactose or fructose, undiagnosed parasites, chronic inflammatory conditions like Crohn's disease or ulcerative colitis, a disrupted microbiome that we refer to as dysbiosis, or sometimes people get diagnosed with SIBO, small intestinal bacterial overgrowth. That's a huge part of the IBS pie. Conditions like hypothyroidism that can secondarily affect the GI tract, diverticulosis, particularly in people over 50, perimenopause. I have even seen colon cancer misdiagnosed as IBS. Number 3, I am not saying that medication for IBS is never a good idea or never effective, but I am saying that it is often an overly expedient solution that doesn't often lead to lasting relief for the simple reason that all those conditions I just named are all treated completely differently. Since there's no one unifying diagnosis of IBS, there can't be one unifying pharmaceutical solution. So that's it for this week's edition of the Gut Bliss podcast on irritable bowel syndrome and pharmaceutical expediency. Coming up next week, we are going to slice up that IBS pie to get to real and lasting relief. We're going to be talking about all those other conditions and more that are often misdiagnosed as IBS and what you need to do to get to the root cause of your symptoms. Go to gutbliss.com for my free 7-day microbiome reboot course. If you like what you're hearing, drop a review and hit that subscribe button. And remember, dirt, sweat, vegetables, the best prescription for a healthy gut.
The information presented in this show is not meant to be medical advice. Consult your doctor before making any decisions about your health. The patients discussed are real people, but names and identifying features have been changed to protect their privacy.